Cystic fibrosis. Cystic fibrosis, CF, is an autosomal recessive disorder caused by a mutation in the genes that code for chloride transport. This is known as the cystic fibrosis transmembrane conductance regulator, CFTR. Mutations in the CFTR gene damage chloride and water transport across the apical surface of epithelial cells in exocrine glands throughout the body. This leads to abnormally thick mucus in the lungs, as well as damage to the pancreas, liver, sinuses, intestines, and genitourinary tract. They all clog up. Damaged mucus clearance decreases the ability to get rid of inhaled bacteria. Neutrophils in CF dump tons of DNA into airway secretions, clogging them up. Presentation. Over 1/3 of CF patients are adults. Look for a young adult with chronic lung disease, cough, sputum, hemoptysis, bronchiectasis, wheezing, and dyspnea, and recurrent episodes of infection. Sinus pain and polyps are common. Gastrointestinal involvement. Meconium ileus in infants with abdominal distension, pancreatic insufficiency, in 90%. With steatorrhea and vitamin A, D, E, and K malabsorption, recurrent pancreatitis, distal intestinal obstruction, biliary cirrhosis. Islets are spared. Beta cell function is normal until much later in life. Genitourinary involvement. Men are often infertile. 95% have azoospermia, with the vas deferens missing in 20%. Women are infertile because chronic lung disease alters the menstrual cycle and thick cervical mucus blocks sperm entry. Diagnostic tests. The most accurate test is an increased sweat chloride test. Pilocarpine increases acetylcholine levels, which increases sweat production. Chloride levels in sweat above 60 MEq/L on repeated testing establishes the diagnosis. Genotyping with CFTR is not as accurate as finding an increased sweat chloride level. This is because there are so many different types of mutations leading to CF. Additional diagnostic tests. Chest X-ray and CT. There is no single abnormality on imaging of the chest to confirm a diagnosis of CF. Findings include bronchiectasis, pneumothorax scarring, atelectasis, hyperinflation. Arterial blood gas may show hypoxemia and, in advanced disease, a respiratory acidosis. PFTs show mixed obstructive and restrictive patterns, decrease in FVC and total lung capacity, and decreased diffusing capacity for carbon monoxide. Treatment. Antibiotics are routine. See the choices listed for bronchiectasis in its video uploaded. Eliminating colonization is difficult and sputum culture is essential to guide therapy. Inhaled aminoglycosides as a treatment method are almost exclusively limited to CF. Inhaled recombinant human deoxyribonuclease, rhDNase. This breaks down the massive amounts of DNA in respiratory mucus that clogs up the airways. Inhaled bronchodilators such as albuterol. Pneumococcal and influenza vaccinations. Lung transplantation is used only in advanced disease not responsive to the therapy previously listed. Ivacaftor combined with lumacaftor increases the activity of CFTR in the 5% of patients who have a specific mutation. Tezacaftor is an alternative.